In today's class, we will be discussing about Cellcept or Mycophenolate mofetil, which is an important drug in post-solid organ transplant patients. It is first FDA approved in 1995. It is an anti-metabolite immunosuppressant approved for patients more than 3 months of age who are undergoing solid organ transplant like kidney, liver and heart. So it is available as capsule, tablets, oral suspension and intravenous preparation. Capsule usually 250 milligram, tablet 500 milligram, oral suspension 35 gram, which on reconstitution become 200 milligram per ml, and intravenous infusion is at 500 milligram in a single dose vial for reconstitution. So capsules are usually blue brown color, 2-piece hard gelatin capsules, blue brown with Cellcept 250 printed on back of the blue cap and Roche on the brown body. 500 milligram is lavender colored caplet shaped tablet, and other oral suspension and intravenous are white crystalline powders. So intravenous is usually when patients cannot tolerate oral medications, and they are usually administered within 24 hours following transplantation until the patient can tolerate oral medication, usually up to 14 days. So the one of the major effect we see of this drug is it can cause neutropenia because so in that case there is a requirement of dose reduction or discontinuation. So that we will discuss in further slides. So what is the mechanism of action of mycophenolate mofetil? It is a selective, uncompetitive and a reversible inhibitor. SUR. It is selective uncompetitive reversible inhibitor of inosine monophosphate dehydrogenase. So, inosine monophosphate dehydrogenase enzymes is involved in the de novo pathway of guanine nucleotide synthesis. So, nucleoside is adenine, guanine, thymine, cytosine. When a phosphate group is attached to that, that becomes a nucleotide. So, the process of nucleotide synthesis involves inosine monophosphate dehydrogenase enzymes, and then only it can get incorporated into the DNA. So that process is selectively, uncompetitively and reversibly inhibited by mycophenolate mofetic acid. And this is a de novo guanine synthesis. This B cells and T cell lymphocytes of our body are dependent on this pathway for their multiplication, for their cell DNA multiplication. Whereas other cell types, there are other salvage pathways also. So the other cell types can depend on other salvage pathways, but B cells and T cells are dependent on this de novo pathway of guanine nucleotide synthesis. So what happens is when you give mycophenolate mofetic acid, it will cause a cytostatic effect on the lymphocytes B and T both. And it inhibits the proliferative response of T and B lymphocytes to both mitogenic and allospecific stimulation. But if you are adding guanosine or deoxyguanosine to the you are giving a mycophenol Cellcept and also you are adding guanosine or deoxyguanosine, then this cytostatic effect on lymphocytes is reversed. That is stopped. And it also inhibits the antibody formation by B lymphocytes. And it also prevents the glycosylation of lymphocyte and monocyte glycoproteins. So for the intracellular adhesion to endothelial cells, which results in diapedesis and extracellular movement of the vascular movement of this in cell adhesion molecules are important, and the glycosylation of these proteins are inhibited by the mycophenolic acid. So that will inhibit the recruitment of lymphocytes into the site of inflammation and a graft rejection. Mycophenolate mofetil do not inhibit early events in the activation of human peripheral blood mononuclear cells such as the production of interleukin 1 and interleukin 2, but did block the coupling of these events to DNA. So basically it is a DNA synthesis inhibitor. So in turn it causes cytostatic effect. The B cells and T cells cannot proliferate and produce antibodies, and also their activation and allospecific stimulation is inhibited, and so their cell adhesion molecule production is inhibited. So this is the basic mechanism of action of mycophenolic acid. So usually in post heart transplant patient, the dose is 1.5 gram given orally BD. If it is IV, infusion should not be given not less than over 2 hours. It should be given over more than 2 hours. In pediatric, we usually start at a dose of 600 milligram per meter square and will gradually increase up to 900 milligram per meter square is the pediatric dose, and As per the body surface area, if the body surface area is 1.25 to 1.5 meter square, then you can give up to 750 milligram BD dose. And if it is more than 1.5 meter square body surface area, it is usually given at 1 gram BD daily dose. Is a pediatric dosing. So what are the contraindication is that if the patient is anaphylactic to molecule of mycophenolate mofetic acid, and another one is a polysorbate. Polysorbate 80 is present in Cellcept IV. So those patients who are allergic to polysorbate IV preparation should avoid using the IV preparation of that. And another one important thing is um, mm, the IV preparation is we rarely use IV preparation. Only if the patient is not able to tolerate oral preparation only. So and it has a very good oral bioavailability also. The molecule get converted by after it is absorbed into the hepatic circulation. It goes enterohepatic circulation and get activated into the active molecule. So oral preparation is better than the IV preparations. And what are the warnings and precautions we should use when using mycophenolate mofetic acid? As one is, since it is multiplying, involving in the DNA synthesis, guanine, de novo guanine nucleotide synthesis, it will affect the multiplication of rapidly proliferating cells. It will cause pancytopenia, it will cause leukopenia, absolute neutrophil count will fall, there will be thrombocytopenia, it can cause pure red cell aplasia. So the blood test monitoring is very important. So when you start a patient on Cellcept, you have to monitor weekly. The CBC has to be monitored for 1 month, followed by bi-weekly, two times in a month for second and third month, and once monthly till 1 year. So that is how you have to monitor the patient. And if there is a fall in absolute neutrophil count less than 1300, we have to discontinue or reduce the dose. And appropriate, we have to find out is there any other causes of neutropenia in that patient, and the patient has to be managed appropriately. And the maximum incidence of this neutropenia occurs between when till the patient is like 6 months of post transplant. Till 6 months of post transplant, there is maximum chances. From 1 month, from the first month to the sixth month of post transplant, the patient has the maximum chances of neutropenia. And other common gastrointestinal complications are like perforation, diarrhea. It is a very common complication. Then it can cause ulceration and bleeding also. And another important thing is hypoxanthine guanine phosphoribosyl transferase deficiency patients should not be given this mycophenolate mofetic acid, like those patients who are having Lesch-Nyhan syndrome and all, because that will result in increased uric acid production in the body, and patient can present with a gout and all. And another interesting adverse effect of precaution we should take is that it can cause an acute inflammatory syndrome, which is paradoxical, because the patient will be having features of acute inflammatory response, increased TLC, raised CRP, ESR without any features of any infection. So that usually occurs when you are using a higher dose of mycophenolate mofetic acid, and once you reduce the dose, that will subside. And just like tacrolimus, the live vaccines has to be avoided when the patient is on Cellcept. And local, if you giving very fast infusion, it can result in phlebitis and thrombosis. And phenylketonuria should be careful, because the oral suspension has aspartame, which can cause a phenylketonuria precipitate. And blood donation has to be avoided for 6 weeks after stopping mycophenolate acid, and semen donation has to be avoided for 3 months after stopping mycophenolate. And there is a potential impairment of driving and use of machinery when a patient is using Cellcept. So from the trials, it has been found that more than 20% incidence of the following adverse effects have been found in patients using mycophenolate mofetil, like diarrhea, leukopenia, infection, vomiting, and certain types of infections, opportunistic infections, both viral, bacterial, as well as parasitic infections and more. And in pregnancy, there is an increased risk of first trimester pregnancy loss, as well as congenital malformations like cleft lip, esophageal atresia, polydactyly, syndactyly has been recorded from post-marketing surveillance studies. But the diarrhea, leukopenia, infection, vomiting, and opportunistic infection are reported in more than 20% of cases. Another other important points are that should not be crushed and should not be opened or crushed Cellcept tablets. And even if the staff who is handling the Cellcept tablet should wear sterile gloves and handle the sample, because even on exposure to skin it can get absorbed, and even contact with eyes has to be rinsed thoroughly, because these are like, if the pregnant staff is handling, there are more chances of embryonal fetal loss. So it should be very careful when you are handling the drug itself. Initial dose of Cellcept should be given as soon as possible following kidney, heart, or liver transplant. And it is best that since it is activating through the intrahepatic circulation, it is best when it is administered on an empty stomach. And since the intravenous preparation does not have any antibacterial preservatives, once it is reconstituted, we should be administered immediately, and also it should not be mixed with any liquid prior to dose administration. And oral suspension, ideally it should be given through a Ryle's tube with a minimum size of 8 friends, that is 1.7 mm internal diameter. And if you are missing a dose of Cellcept, it should be taken as early as possible. The patient has to take the dose. If other than that, like if the next dose is within 2 hours, then you can skip that. Otherwise, you should take as when you are when you have missed a dose. And if it is near to 2 hours, they can continue with the next dose. So IV preparation once usually given. The oral preparations are given as soon as the patient undergo transplant, while IV preparation are usually started within 24 hours. So, Cellcept intravenous infusion is incompatible with other intravenous infusion solutions and should not be mixed or administered concurrently via the same infusion catheter with other intravenous drugs or infusion admixtures. So, and does not contain an antibacterial preservative. Therefore, reconstitution dilution must be performed under aseptic precautions. So these are the embryo fetal toxicity, first trimester pregnancy loss, congenital malformation, external ear and other facial abnormalities like cleft lip, palate, anomalies of the distal limb, heart, esophagus, kidney and nervous system. And just like tacrolimus, there are increased incidence of lymphoma and other malignancies, lymphomas. But in pediatric patients, most common lymphomas reported are post-transplant lymphoproliferative disease, usually by Epstein-Barr virus. And also skin malignancy. So careful adequate exposure to sunlight should be prevented. UV exposure should be avoided, and the skin examination should be done periodically. And serious infections, just like tacrolimus, there is polyoma associated nephropathy, especially due to BK virus, JC virus associated progressive multifocal leukoencephalopathy, where the patient can present with a ataxia, confusion, and hemiparesis. Cytomegalovirus infection more common in donors recipients who are CMV seronegative, who get a CMV positive donor, and also viral reactivation in patients infected with hepatitis B and C, and also COVID-19 are the serious infections reported. And patients receiving Cellcept should be instructed to report immediately if there is any evidence of infection, unexpected bruising, bleeding, or any other manifestation, because this is the one which is affecting DNA synthesis, so it can cause bone marrow depression. So just like the monitoring, that is weekly for the first month, twice monthly for the second and third month, and monthly for till 1 year. Cellcept is an inosine monophosphate dehydrogenase inhibitor. Therefore, it should be avoided in patients with hereditary deficiencies of hyposanine guanine phosphoribosyl transferase like Lesch-Nyhan and Kelly-C-Miller syndrome, because it causes an exacerbation of disease symptoms of Lesch-Nyhan, which is characterized by overproduction and accumulation of uric acid, leading to symptoms associated with gout like acute arthritis, trophy, nephrolithiasis or urolithiasis, and renal disease including renal failure. So just like we have described acute inflammatory syndrome, paradoxical pro-inflammatory state, there will be fever, arthralgia, arthritis, muscle pain and elevated inflammatory markers including C-reactive protein, ESR, without evidence of an infection or underlying disease recurrence. And symptoms occur within months to weeks of initiation of treatment or a dose increase. And usually within 24 to 48 hours of discontinuation, the symptoms will improve. So the most common opportunistic infections in patients receiving Cellcept with other immunosuppressants were mucocutaneous candida, CMV viremia syndrome, and herpes simplex. And CMV viremia incidence in patients using Cellcept is 13.5%. Severe neutropenia is reported in 2.8, about 3% of patients of post-heart transplant. And they reported that diarrhea is a very common side effect, adverse effects in patients receiving Cellcept, and it is in endoscopic studies are revealed there will be intestinal villus atrophy in patients receiving this Cellcept. So 3.8% severe neutropenia will be developing, and 13% patients will be developing CMV viremia syndrome in patients receiving Cellcept. And the drug interactions commonly reported include magnesium or aluminum hydroxide containing drugs will reduce the systemic absorption. So we should maintain a gap of 2 hours between them. PPIs reduce systemic absorption. So there should be a gap between administration of PPIs and Cellcept. And that those drugs which alter the endohepatic circulation will interfere with the MPA systemic absorption, like cyclosporin, trimethoprim, cyclosporin A, that is cotrimoxazole, bile acid sequestrants like cholestyramine, rifampin, as well as aminoglycosides, cephalosporins, fluoroquinolones, and penicillin class of antibiotics. So they can interfere with the Cellcept absorption. So drugs which induces glucuronidation, like a telmisartan, decreases the systemic absorption of MBA, and those which inhibit glucuronidation increases the systemic effect, like isovuconazole. So telmisartan along with the Cellcept should be avoided because it will reduce the systemic absorption. While we should be careful with giving isovuconazole along with the Cellcept. And calcium free phosphate binders, so those patients with CKD, there should be a dose gap of at least 2 hours. So calcium phosphate binders, aluminium magnesium hydroxide, PPIs, 2 gaps, tell me certain these have at least 2 hour gaps as to maintain. Also these antibiotics, because they all antibiotics which alter the endohepatic circulation will reduce the systemic absorption. And drugs which undergo renal tubular secretions, because mycophenolic Cellcept also competes for renal tubular secretion, so that can cause an increase in the levels of the drugs, like acyclovir, ganciclovir, valganciclovir, probenecide, and valacyclovir. And also Cellcept may be used for heart or liver transplant patients with severe chronic renal impairment if the potential benefits outweigh the potential risks. What happens if there is an overdosage? Hematological abnormalities. The patient can present with leukopenia, neutropenia, and gastrointestinal abdominal pain, diarrhea, nausea, vomiting, and dyspepsia. Cellcept and phenolic glucuronide metabolite of mycophenolic acid are usually not removed by hemodialysis. However, at very high concentration, some amount of the metabolite, glucuronide metabolite of Cellcept is removed. And we can also use other measures. So hemodialysis can be used if there is very high concentration, that is more than 100 microgram per ml. And by increasing the excretion of the drug, by bile acid sequestrants can be used for increasing the elimination, like cholestyramine can be used for increasing the excretion of the drug. So this is how we treat an overdosage. Thank you.